Hi everybody, I am Dr. Armen, Professor Armen Astvatsatryan from Biographical, Armenia, and today we'll talk about diverticulosis. Well, of course, about colonic diverticulosis. So what is colonic diverticulosis? Colonic diverticulosis is the presence of one or more diverticula in the colon. More diverticula are asymptomatic, but some become inflamed or bleed. Diagnosis by colonoscopy, capsule endoscopy, barium enema. So barium enema, computed tomography, or MRI. Asymptomatic diverticulosis requires no treatment. When symptoms develop, treatment varies depending on clinical manifestations. A colonic diverticulum is a sac-like pouch of a colonic mucosa, so of colonic mucosa and submucosa that protrudes through the muscular layer of the colon. Because it doesn't contain all layers of the ball, it's considered pseudo-diverticulum. Pseudo-diverticulum. Okay?
Pseudo-diverticulum.
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 Pseudo, because not all layers in it. Although diverticula can occur anywhere in the large bowel, they usually occur in the sigmoid portion of the colon. They rarely occur below the peritoneal reflection and involve the rectum. Diverticula vary in diameter, but typically are 3 to 10 millimeters in size. Giant diverticula, which are extremely rare, are defined as diverticula more than 4 centimeters in diameter. Size up to 25 centimeters have been reported. 25 centimeters have been reported. People who have colonic diverticulosis usually have several diverticula. Colonic diverticulus usually have several diverticula. Okay?
People who have colonic diverticulosis usually have several diverticula.
Several diverticula. Okay? Okay, thanks. Thanks for it. You're giving the cue. Thanks. Okay, so let's go and understand what is diverticulosis. Let's continue. Diverticulosis becomes more common with increasing age. It's present in 3/4 of people aged 80 years plus. 80 years plus, diverticulosis. So, etiology. The etiology of colonic diverticulosis is multifactorial.
Multifactorial.
Yeah, multifactorial, thanks for suggesting, and not entirely known. Several studies have suggested a correlation between symptomatic diverticular disease and environmental factors such as diet, low in fiber, and high in red meat. Fiber maybe, but what about meat? No idea. No, maybe due to gas formation. Sedentary lifestyle, obesity, smoking, and the use of non-steroidal anti-inflammatory drugs, corticosteroids, and opiates. Opiates. Why opiates? Actually, no idea.
Opiates.
Other possible risk factors include heritable factors and alterations in the colonic wall structure and motility. Diverticula are possibly caused by an increase in trigeminal pressure, which leads to mucosal extrusion through the weakest points of the muscular layer of the ball, areas adjacent to intramural blood vessels. The etiology of giant diverticula is unclear. One theory is that a narrow neck opening leads to a bell valve effect with intermittent obstruction of the opening, causing the diverticulum to enlarge. A very large giant diverticulum is often a true perforation of a small diverticulum that was contained and walled off and became lined mostly by granulation tissue. Well, maybe. About symptoms. Most 80% patients with diverticulosis are asymptomatic or have only intermittent constipation. About 20% become symptomatic with pain or bleeding, with inflammatory or hemorrhagic complication develops. Huh? Hemorrhagic complications develop. About 20%. So patients with diverticulosis sometimes develop non-specific gastrointestinal symptoms, GI symptoms. GI means gastrointestinal symptoms, including abdominal pain, bloating, constipation, diarrhea, and passage of mucus from the rectum. Passage of mucus from the rectum. This constellation is sometimes referred to as symptomatic uncomplicated diverticular disease. However, asymptomatic diverticular disease. However, some specialists believe these symptoms are due to another disorder, for example, irritable bowel syndrome. Yes, for me also, I think in this way. And the presence of a diverticula is considered rather than causal. Is coincidental than causal. So about complications of diverticulosis. Complications of colonic diverticular disease are more common among people who smoke, who obese, have HIV infection, or use non-steroid anti-inflammatory drugs, and undergoing cancer chemotherapy. Complications occur in 15 to 20% of patients and include diverticulitis. Concerning diverticulitis, Concerning diverticulitis, maybe we'll talk about diverticulitis in another lecture or at the end of this lecture. It depends on time. So diverticulitis is a complication of diverticulosis, diverticular bleeding, segmental colitis associated with diverticular disease. Okay?
Segmental colitis associated with diverticular disease, SCAD.
So segmental colitis associated with diverticular disease, also called SCAD. So diverticulitis is a painful inflammation of a diverticulum. It may be uncomplicated or complicated. Diverticular bleeding occurs in 10 to 50% of patients with diverticulosis. And SCAD, so segmental colitis associated with diverticular disease, refers to manifestation of colitis, for example, hematochezia, abdominal pain, diarrhea, that develop in a few patients, about 1%, with diverticulosis. The degree to which the diverticulosis is a causal is unclear. Causal. Diverticular bleeding. Diverticular bleeding is the most common cause, up to 50% of brisk lower GI bleeding, gastrointestinal bleeding, in adults. A study showed that the cumulative incidence of lower gastrointestinal bleeding from diverticulosis was about 2% at 5 years and 10% at 10 years. The pathophysiology of diverticular bleeding. Diverticular bleeding is unknown, but several mechanisms are hypothesized, including local trauma from impacted feces fecally, feces.
feces,
Feces in diverticulum that can erode the adjacent vessel, enlargement of the diverticulum that can stretch the ultimately rear the vessel, and non-steroidal drugs have been reported to increase the risk of the hemorrhage. Hemorrhage. Although most diverticula are in the distal left column, half of diverticular bleeding occurs from diverticula in the proximal right column. Patients with pancolonic diverticulosis have a higher incidence of bleeding. Diverticular bleeding manifests as penless hematochezia. Because the bleeding vessels is an arteriole, the amount of blood loss is usually moderate to severe. Fresh blood or maroon-colored stool is a typical manifestation. Rarely, right-sided diverticular bleeding can manifest as melena. Diverticular bleeding usually occurs without concomitant diverticulitis. Diverticulitis. The majority, 75%, of episodes of bleeding cease spontaneously. The remainder require intervention, typically endoscopic. Patients who have had a diverticular bleeding episode have an increased risk of bleeding, of rebleeding. After a second episode of diverticular bleeding, the risk of rebleeding is 50%. Concerning diagnosis of colonic diverticulum, usually colonoscopy or computer tomography. Asymptomatic diverticula are usually found incidentally during colonoscopy, capsule endoscopy, barium minima, computer tomography, or MRI. Lower gastrointestinal bleeding due to diverticulosis is suspected when painless rectal bleeding develops, particularly in older patient or in patient who has history of diverticular disease. Evaluation of lower gastrointestinal bleeding typically includes colonoscopy, which can be done after rapid colonic preparation. If the source cannot be seen with colonoscopy and ongoing bleeding is sufficiently rapid, so more than 0.5 to 1 milliliter a minute, computer tomography, angiography, or radionuclide imaging may localize the source. Radionuclide is okay. So concerning treatment. So no treatment for asymptomatic diverticulosis. Management of specific symptoms and diverticular bleeding treated as a lower gastrointestinal bleed. Asymptomatic diverticulosis requires no treatment or dietary changes. There is no association between consumption of nuts, seeds, corn, or popcorn and diverticulitis, diverticular hemorrhage, or uncomplicated diverticulosis, and avoidance of this food is no longer recommended. So non-steroid and opioid analgesics may increase the risk of diverticular perforation and bleeding. Therefore, these drugs should be used with appropriate caution and after extensive discussion with the patient about the risks. For diverticulosis with non-specific gastrointestinal symptoms, treatment is aimed to reducing spasm of a segment of a colon. A higher fiber diet is often recommended and may be supplemented by psyllium seed preparations or bran together with adequate fluid intake. However, the role of fiber in the treatment of diverticulosis is limited, but I think it's quite reasonable. In general, data are inadequate to confirm beneficial effects of fiber. Bulk-forming laxative should be considered for people with constipation. Antispasmodics, for example belladonna, are not benefit and may cause adverse effects. Low fiber diets are not helpful. Surgery is unwarranted for uncomplicated disease for giant diverticula. There is no association between consumption of nuts, once again please, there is no obvious association between consumption of nuts, seeds, corn or popcorn and diverticulitis, diverticular hemorrhage or uncomplicated diverticulosis, and avoidance of these foods is no longer recommended. So concerning diverticular bleeding treatment, diverticular bleeding stops spontaneously in 75% of patients. Initial management is for lower gastrointestinal bleeding. Treatment of diverticular bleeding is often given during the diagnostic procedure. Colonoscopic identification of bleeding site, which can occur up to 20% of the time, allows for endoscopic options to control bleeding, including epinephrine injection. Epinephrine.
Epinephrine.
Epinephrine. Epinephrine injection, adrenaline, application of endoclips or fibrin sealant. Fibrin sealant. Yeah. Fibrin sealant. Fibrin.
Fibrin sealant.
Fibrin sealant.
Fibrin sealant.
Okay. Fibrin sealant, heterprop or bipolar coagulation. Bipolar or bipolar. Bipolar coagulation and band ligation. Angiography can help with diagnosis of the source of bleeding and treatment of ongoing bleeding. During angiography, a number of techniques can be used to control the bleeding, particularly embolization, and less often vasopressin injection. Embolization is successful about 80% of the time. Angiographic complications of bowel ischemia or infarction are less common, less than 5%, with current super-selective catheterization techniques. Surgery is rarely needed, but it's recommended for patients who have had multiple or persistent episodes of diverticular bleeding refractory to therapy, who have hemodynamic instability despite aggressive resuscitation. If angiography or surgery is being considered, identifying the specific bleeding diverticulum endoscopically or using a nuclear medicine study during active bleeding gives direction to the interventional radiologist and may limit the size of a potential surgical resection. When the bleeding site is known, the need for subtotal colectomy, with its associated higher morbidity and mortality, is markedly reduced because a hemicolectomy or segmental colectomy may be done instead. However, patients who have continued a life-threatening hemorrhage and no identifiable bleeding diverticulum may require a subtotal colectomy. Okay, key points about diverticulosis. Colonic diverticula are sac-like mucosal pouches that protrude from the colon. Diverticulosis is increasingly common with age, and it's present in about 75% of people more than 80 years. Diverticulosis is usually asymptomatic, but about 20% of patients develop symptoms and/or complications including inflammation, diverticulitis, and lower gastrointestinal bleeding. Asymptomatic diverticulosis requires no treatment. Diverticular bleeding stops spontaneously in about 75% of patients, control the remainder during colonoscopy or angiography, or rarely with surgery. Okay, let's continue with diverticulitis. So diverticulitis is inflammation with or without infection. Diverticulitis is in
Diverticulitis.
Yeah.
Diverticulitis.
So diverticulitis is inflammation with or without infection of a diverticulum, which can result in phlegmon of the bowel wall, peritonitis, perforation, fistula, or abscess. The primary Symptom is abdominal pain. Diagnosis by computer tomography. Treatment is with bowel rest, sometimes antibiotics, and occasional surgery. So, diverticula are, as we said above, are usually asymptomatic but sometimes become inflamed. Diverticulitis. A 2013 study reported that 4.3% of patients with documented diverticulosis developed diverticulitis over an 11-year follow-up period. Less than 5%. So not very often. Diverticulitis that's managed non-operatively can recur as either on an acute or chronic process. Either. As either an acute or chronic process, either or either. The risk of recurrent acute episodes is up to 39%, although reported rates vary widely. A large population-based study found that after an episode of acute diverticulitis, the recurrence rate at 1 year was 8%, and to 10% was 22%. And at 10 years, so the recurrence rate 1 year was 8%, at the 10 years was 22%. About half of second episodes of diverticulitis occur within 12 months. In some patients, however, recurrence manifests as chronic, ongoing abdominal pain. This may develop after one or more acute episodes. The etiology and pathophysiology of diverticulitis is not fully understood and may vary among patients. It has long been thought that diverticulitis occurs when a micro or macro perforation develops in a diverticulum, resulting in the release of interstitial bacteria and the triggering inflammation. However, emerging data suggests that in some patients, acute diverticulitis is more of an inflammatory than an infection process. Actually, infection also is inflammation, my friends. Furthermore, cytomegalovirus may be a trigger of that inflammation. Active viral replication has been found in affected colon tissue. In over 2/3 of patients with diverticulitis. A 2017 study suggested a direct correlation between red meat consumption per week and the incidence of diverticulitis. But actually, there is no association between consumption of nuts, seeds, corn, and popcorn and development of diverticulitis as was previously thought. We talked about several times. So, diverticulitis can be classified as complicated and uncomplicated. Uncomplicated, the most common. Uncomplicated, the 75 to 80% manifestation of diverticulitis. Complicated diverticulitis, defined by the presence of abscess, fistula, obstruction, obstruction or free perforation. Several classifications exist. Complication can develop after perforation of inflamed diverticulum. About 50% of patients with complicated diverticulus have a pericolic or intramesenteric abscess. Patients have lower quadrant symptoms, have lower quadrant abdominal pain and tenderness, and often have a palpable sigmoid. Pain is occasionally suprapubic. Yeah. Suprapubic. However, Asians with diverticulitis often present with right-sided pain due to right colon involvement. The pain can be accompanied by nausea, vomiting, fever, and sometimes even urinary symptoms as a result of bladder irritation. Peritoneal signs, for example, rebound or gardening, may be present, particularly with abscess or free perforation. Fistula may manifest as a pneumaturia, fecaluria, the feces in the urine. Feces in the urine.
Feces in the urine,
feculent vaginal discharge, or feculent
Каловые выделения из
feculent vaginal discharge. Feculent vaginal discharge.
feculent vaginal discharge, or a cutaneous or myofascial infection of the abdominal wall, perineum, or upper leg. Patients with bowel obstruction have nausea, vomiting, and abdominal distension. Bleeding is uncommon. Recurrent episodes of acute diverticulitis manifest similar to initial episodes. They are not necessarily more severe. And concerning the diagnosis of colonic diverticulitis, abdominal and pelvic computer tomography, colonoscopy after resolution. Clinical suspicion is high in patients with known diverticulosis, of course, who present with characteristic abdominal symptoms. However, because other disorders, for example appendicitis, colon or ovarian cancer, inflammatory bowel disease, may cause similar symptoms, testing is required. Diverticulitis is evaluated with computer tomography of the abdomen and pelvis with water-soluble contrast given orally and rectally. Intravenous contrast also is given when not contraindicated. However, findings is about 10% of patients cannot distinguish diverticulitis from colon cancer. MRI is an alternative for pregnant and young patients. Colonoscopy is often recommended 1 to 3 months after resolution of the episodes to assess for cancer. However, in the absence of high-risk signs, for example complicated diverticulitis and complicated diverticulitis with imaging abnormalities of a typical course, family history of colorectal cancer, anemia, weight loss, the likelihood of malignant lesions or advanced adenomas after an episode of uncomplicated acute diverticulitis is low. So treatment varies with severity. Liquid diet for mild disease, nothing by mouth for more severe disease. Nothing by mouth for more severe disease.
Nothing by mouth for more severe disease.
For more severe disease. So, sometimes antibiotics. Computer tomography guided percutaneous drainage of abscess, and sometimes surgery. A patient who is not very ill is treated at home with rest and liquid diet. Symptoms usually subside rapidly. Patients with more severe symptoms, for example pain, marked leukocytosis, should be hospitalized, as should be patient taking prednisone, who are at high risk of perforation and general peritonitis. Treatment is bed rest, nothing by mouth, and intravenous fluids. So, concerning the diverticulitis key points. Diverticulitis is inflammation and infection of a diverticulum. Inflammation remains localized in about 75% patients. The remainder develop abscess, peritonitis, bowel obstruction, or fistulas. Diagnosis using abdominal and pelvic computer tomography with oral, rectal, and intravenous contrast. Do colonoscopy 1 to 3 months after the episode to look for cancer. Management depends on severity, but typically includes conservative management, often antibiotics, and sometimes percutaneous or endoscopic ultrasound-guided drainage or surgical resection.
Drainage.
Or surgical resection. Surgical resection.
Surgical resection.
So, my friends, that's all concerning diverticulitis and diverticulosis and diverticulitis. Thanks for your attention. See you in other lectures. Please don't forget to make your donations to our channel, because without your donations our channel cannot exist. How to make it? Direct using YouTube options or through my MasterCard. You can find this data in description actually of this video, not description of this video in YouTube. Bye. See you in YouTube or in this podcast. See you in another lectures. God bless you.